the business end of Sutter Coast has squashed the doctors in this whole outfit, because there's obviously money's involved. And the second thing is, besides writing letter, I've been on boards before, if they've already rigged the vote, so the vote has already been made, is there any way to rescind that, besides writing letters? You've tried, and last week, is there any other way to rescind it? The board's already voted.
It's another excellent question, and we have formed a committee with the healthcare district. 2 supervisors signed on as of today, and we'll have representatives from other government and community leaders on that committee. There's also a document called a lease agreement, which transferred the monopoly power, essentially, of the hospital that Dwayne was talking about, that may still be enforceable, and we're pursuing that as well. So we are looking at every avenue, but the one that I think may be the most powerful is the community approach. I was told by some contacts in San Francisco yesterday that Sutter Health is the master of the courtroom. And if you go to court with Sutter Health, be prepared to lose, but if you win anything at all, it's a victory. So we're pursuing that as well. In fact, it was the mention of legal action to Mike Cohill that got them to not sign the merger documents. The merger documents were supposed to be signed at the board meeting on April 5th. And when I mentioned that the healthcare district was considering legal action to enforce their lease agreement, that's when the documents were put away and not signed. Otherwise, this whole thing would already be in place.
So do you write Sutter Coast, or do you write the triplicate?
The triplicate. Yes.
Corporatism notwithstanding, Citizens United notwithstanding, this is federal tax dollars. Is there a possibility of a federal injunction?
That's an excellent question, and that's one that I hadn't considered until just now. You bring up a great point. A program designed to improve access is being usurped to reduce access and guarantee profits. And again, this is a nonprofit institution. I knew you'd understand. Yes. Jim's going to talk to that somewhat. I'll just leave you with salaries have more than doubled in the last 3 years for the Sutter executives. It is a matter of public record, and Jim will be speaking to that in just a few minutes. Yes, Dan.
My name is Daniel Bernhardt. I've been here 15 years. I used to work at Sutter Close Hospital for all 5 years. My wife worked there all her life. And nonprofits sometimes, I think, could be a big problem. I heard from an administrator that's now retired. I used to work at Sutter. He said that nonprofit, you only get so many millions. If you make over that, you lose that. That's a nonprofit. I've always said, why can we do profit? And what happens?
What nonprofits don't do is pay shareholders. They have to distribute the profits to the executives and the employees. That's the serious answer to your question. Yes, in the back, please.
Can you tell us the names of the supervisors that are backing you and the supervisors that have decided?
I think they're all backing us. The ones on the committee, I understand, and Mr. Reichman can confirm this. The supervisors on the committee will be Martha McClure and Leslie McNamer. David Finnegan was extremely energized, I'll use the word. Yes?
I was wondering if in your research you found out why the billing, there's 14 of us in the billing office that lost our jobs. We understood because of the new regulations for Medicare and that we didn't have the computer program to do that. So I don't know if that came up in your research, if that was in fact true.
It did come up, and let me tell you a little story because of some of the problems Kevin mentioned. Some of the billing had to come back and be done on the same computers that wouldn't work before. Does that help? Yes?
I don't see Dr. Polidor.
Dr. Polidor, and I'll report the first roll call. I'm not going to report that second roll call because I've been warned, but the first roll call came out in the newspaper, and he voted for regionalization. He is also an employee of Sutter Pacific Medical Foundation. His CEO is the regional president. That's Mike Cohill, the same person that I spoke about earlier. I'll just leave it at that. Thank you. Yes,
Can I say one more thing?
sure.
In the past, I've noticed that a lot of doctors came to this area and they didn't stay and ended up moving on. There's even nurses that came here and moved on because there's just nothing here to attract doctors and nurses. So we needed some type that attracts nurses, doctors, and families to this area to keep them instead of losing them.
It's a great point. When I was a young surgeon, I came here because there was a new hospital and the community was growing. There's no chance that I would come here again if I thought there was any possibility of critical access. Critical access right now means that patients scheduled for surgery who have had valve preps, they're ready for valve surgery, are turned away. This is not theoretical. This is what a doctor told me 3 weeks ago at Sutter Lakeside. Cancer patients have to get on airplanes for IV hydration to be done in San Francisco instead of locally. Their oncologist is in Lakeside and their care is in San Francisco. Yes?
Dr. Duncan, a lot of what's done at Sutter Coast Hospital are testing for various doctors in the area that don't have facilities and for x-rays, et cetera. What happens to that with this critical care thing?
That's a great question also. The way healthcare works is when you have more providers, everything feeds into that. When you add a vascular surgeon, you need to do vascular radiology. When you cut services, everything shrinks too, because you can't keep open services where there's no support specialty physicians. So everything shrinks somewhat. Yes, Dora? They tried to eliminate the hospital, the ER group and the radiology group last year, but thanks to the efforts of Dr. Caldwell, he was able to stop both of those groups from being eliminated, and the ER physician was notified that her job was eliminated by a competing company calling her and asking her if she wanted to work for them. And she said, "Thank you very much, but I already have a job right here in the Sutter Coast ER." And they said, "Actually, you don't." So this is how business is done over there. Yes.
I don't have a question. I guess I want to make a statement that people have to really realize that if you're transferred out, it could be to Portland, it could be to Timbuktu, it could be to Utah, because you have to have a receiving physician. And if I got a man, you don't have any insurance by chance, they don't have to accept you. So this is really a very serious issue that we're talking about.
Thank you for bringing that up. I can say what I was going to say before now. When you're on an air ambulance flight, you ask yourself 4 questions. You want to know who's going to be your doctor. It'll be somebody new. You want to know how they're going to get your medical history, which is back where you came from. Now, some of that can be faxed, but there's a difference between person to person. You want to know how you're going to get back, and you want to know how they're going to do the follow-up. When you're in San Francisco and you have an operation,
And your family.
And your family.
that's the question you ask when you're on the ground and your wife calls. That's the 5th question. Thank you. Go ahead.
Another question. They can't transport any patient that's not stable. So what are you going to do with a patient that's not stable?
If you met the 25 maximum, that's a great question. I don't know the answer to that question. I know it's a hard limit. We've looked very carefully on the critical access program. My suspicion is a few beds are set aside. For example, I know for sure that maternity beds and pediatric beds are set aside, which is nice, except that is then subtracted off the 25 number. So now you're down to maybe 21. So maybe there's a trauma bed set aside too.
What's going to happen to any ICU beds if the length of stay can't be over 4 days? Then does that just automatically nix the ICU?
That's another great question. My answer is, it's hard to imagine an ICU in a hospital where you can only stay 4 days. Yes, the front.
I work for Critical Access Hospital in Nebraska, and even if you're unstable, they have skilled nurses, like nurses that can transport, and they transport.
So there's just, I mean, this is exactly what's happening clearly. Again, this isn't theory. 4 to 5 people every day getting, they usually use helicopters over there, but anyway, in an air ambulance flight, which, you know, people said, well, the air ambulance companies will be happy with that. But the answer is really they won't be happy because there are lots of people in this town who can't afford air ambulance medical. membership, they'll be transported too, and the company will obviously absorb that cost. Yes?